Yeah, my name's Peter Carey. I'm a urologist. Been here in Fredericksburg for 24 years. I'm from New England, but I was in Charlottesville, did all my training in Charlottesville from 79 to 89. Married a woman from Fredericksburg in 82, and then after I finished my residency, came back here. And first I joined Dr. Beeman, who many of you may have heard of. He and Dr. Gray were the first two urologists, and I worked on Princess Anne Street, right next to Carl's. Did about 4 or 5 years there. Then we moved into the Tompkins Martin building next to Mary Wash. Did probably 14 years there, and then we built a building behind, kind of up off Cowan Boulevard. There's 3 or 4 doctors' offices up there, so we moved into that office. I've got 7 partners, so we've expanded quite a bit. And 2 years ago, we opened our office down here to service Spotsylvania Regional Hospital, and we're in the building kind of right across 95 from Spotsylvania Hospital, and that's where I've been this week working, and it's been busy. It's been fun. So that's who I am. I'm a urologist. One of the more common things we treat in urology, we treat a lot of stuff. A lot of people ask you, why'd you go into urology? It's a surgical field, but it's kind of it's enjoyable. Treat a lot of kidney stones, a lot of prostate issues. There's a lot of female urology, women with pelvic prolapse and incontinence and things like that. A lot of cancer surgery, kidney cancer, bladder cancer, prostate cancer. But it's an enjoyable surgical field. It's a little different from general surgery, which deals more with the liver and the intestines and the appendix and the gallbladder and that type of stuff. But far and away, the most common patients we see are middle-aged men and above who have male health issues, as this talk is called. Most of them pertain to the prostate. I had a couple of topics that I wanted to cover, and then I'll just let anyone ask questions. But 3 of the more common prostate problems we deal with are prostatitis, which is an inflammation of the prostate, primarily younger guys, and prostate enlargement. That's BPH, we call it, benign prostatic hyperplasia. That's the actual physical growth of the gland as we get older, as men get older. And then finally, prostate cancer, which is a completely separate item. And 2 or 3 of these conditions can coexist. A man can have BPH and prostatitis, or he can have BPH and prostate cancer. So it's not mutually exclusive. Men can have mixes of those 3 conditions. But let me just remind everyone of the anatomy. It's it's a little gland. It's part of the reproductive tract. It makes a fluid. It's a gland that makes a fluid, just like the salivary gland or the pancreas. It makes a fluid that is a major component of semen, which is an important part of male reproduction. Beyond that, it's a cause of a lot of troubles for men, during their lifetime. But it does have that important physiologic role. It's a reproductive organ. The urethra runs right through the middle of it. Okay, so for a man to urinate, the bladder has to contract. There's a sphincter muscle, it's called, which is runs right through the prostate. That has to relax in order for the man to empty his bladder. So that explains a lot of the symptoms. The urethra down below has no muscular function. It's just kind of a dumb tube that just allows the urine to pass through. But as men age, the prostate, for reasons that aren't really well understood, the prostate enlarges. When a guy is, let's say, 25 years old, his prostate is 20 grams roughly, which is about the size of a walnut. It's a very small organ in a 20-year-old. It can double, triple, quadruple in size, so that by the time we see a lot of our patients when they're in their 60s, 50s, 60s, and 70s, it's 40, 50, 60, 80 grams in size. So that's quite a bit of growth if you think about it. It's a similar kind of disease as women's fibroids. Women in their uterus will get these kind of rubbery tumors of their uterus called fibroids. BPH, the enlargement of a prostate in men as men get older, is a very similar process. If you think of those rubbery kind of muscular nodules that women can get on their uterus, picture the same occurrence happening in the middle of the prostate gland here. And what it does, as you can guess because of its location, is it pinches the urethra. It makes it, the prostate's growing out, but it's also squeezing the urethra here, so it's harder for that urethra to relax and harder for men to urinate. So as men get older and as this disease we call BPH, as it progresses, the bladder symptoms start to bother the man more and more and more. And those symptoms are, as everyone knows from television, you know, getting up at night more frequency during the daytime, slower stream because you've got, you know, this compressing effect on the urethra, and what's called urgency, which means when you feel like you have to go, you got to go very quickly, or else you may not make it to the restroom in time. All of those symptoms are what we call obstructive symptoms, and they're from BPH. As the prostate gets bigger, that's what happens to men. You can diagnose it with a history. You talk to the man and he'll tell you what his problems are. You have to do a rectal exam and you can feel the prostate is enlarged. As I said, the 20-year-old's prostate is very small. It's about 2 finger breadths, so boom, boom, you can feel it's that tiny. But as a man gets BPH, I mean, the gland may be literally that wide, you know, almost like a small tangerine or a small lemon. It becomes physically quite enlarged. So physical exam helps. Sometimes we do a test called a flow rate, which we quantitate a man's urinary flow, and if it's low, then that supports the diagnosis that the man's obstructed and that he needs some help for treating his BPH. As far as treatment goes, you know, up until probably 79 or 80, we had no medical treatment whatsoever for BPH. Then starting in the 80s, we started to use these drugs called alpha blockers, which are drugs like Hitrin and doxazosin and Flomax, which is tamsulosin. And then also back in the 80s, another group of drugs came up that would actually shrink the gland. The alpha blockers don't shrink it. What they do is they relax that little tube right there and make it easier for the bladder to empty itself. The other drugs, like finasteride and Avodart, actually shrink the gland. They're more of a hormone type. They affect the hormone metabolism of the gland. So we have 2 weapons now that we can use as opposed to surgery. Up until about the early 80s, all we had to offer was surgery, what's called the roto-rooter. Men call it that. We call it a TURP, a T-U-R-P, which is not a fun operation. It's a very successful operation, but it's not a fun operation for men to have unless they need it. It's a fairly bloody operation. You have to have a catheter in for several days. And if a medicine will solve the problem and avoid the surgery, well then obviously men will flock to that medicine rather than have the surgery done. And it's, you know, similar to women. If there's a way to avoid a woman having a hysterectomy, then obviously women are going to flock to that non-surgical treatment. Everyone wants to avoid surgery wherever possible. So the primary treatment for BPH, for this benign prostate enlargement that I've been describing, is medical. Now, that's always our first step, is a drug like Flomax or Avodart to try to shrink the gland, relax the gland, and the men will, I'd say 80% of the time, will respond and they'll have improved flow, they'll get up less at night, they'll feel better, they're happy. If it doesn't work though, then we do offer them these new laser TURPs, they're called, where we anesthetize the man, obviously, we put him to sleep, and then pass a scope up here and hollow out the prostate, just like you're coring an apple with a laser. And it doesn't bleed as much as the old way of doing it. So that's highly effective if the pills don't work. So that's BPH. The next I wanted to touch on is prostatitis. Prostatitis tends to be in younger guys in their 20s, 30s, 40s. It tends to cause pain more. BPH, what I've just been talking about, doesn't cause any pain. It may be a pain in the neck because you got to get up at night and go more often, but it doesn't actually hurt down here. With prostatitis, it's a little different. With prostatitis, men tend to get achiness in the testicles, achiness down their thighs, their low back, their pelvic region here. They just don't feel right. They tend to have some sexual dysfunction, some ejaculatory dysfunction, some frequency of urination. So some of the symptoms do overlap with BPH. They will have more urination at night, a weaker stream, similar to the BPH. But the problem is not that the gland has doubled or tripled in size like in BPH. The problem is that there's an inflammation in the prostate which is causing all of these symptoms. And that inflammation can be due to a bacteria, which is why we often give antibiotics for prostatitis. Sometimes it's not due to a bacteria. We don't know why the gland is inflamed. We see it, for example, in guys that do, you know, that get on a fitness craze and they'll do 500 sit-ups or crunches in a day. You know, anything that you're constantly pushing with abdominal pressure on the prostate gland or heavy lifting, things of that nature, that can cause the prostate to become inflamed and irritated and painful as well. But the diagnosis is generally by history and physical exam. There's no blood test that proves it. There's no x-ray that proves it. And the treatment, as I said, is usually usually with antibiotics and anti-inflammatory medicines like Advil, basically. Drugs like Celebrex or Advil or Motrin or things of that nature. So that's prostatitis. The final one I wanted to talk about is prostate cancer. Prostate cancer, you know, is a big item in the news over the last 20 years. It's extremely common. It's the #2 most common cancer in men. But the good news is it ranks probably 9th or 10th in terms of cause of cancer death. Now, what does that mean? That means a lot of men die with their cancer, prostate cancer, rather than from their prostate cancer. And we've known that for many, many years. It's a very slow-growing cancer that oftentimes is not lethal. However, back in about 1980, we found this blood test called prostate-specific antigen. And someone discovered that in men with prostate cancer, this protein, which, by the way, PSA is a protein made by the prostate gland, okay? If you collect prostate fluid, let's say from a man's semen, it's got huge amounts of PSA in it. Well, a little bit of it leaches into the bloodstream, okay? So if I draw blood from a patient, there'll be a tiny amount of PSA, prostate-specific antigen, it's a protein, in the bloodstream that came from his prostate gland. Well, it was discovered back in the early 80s that men with prostate cancer leak a little more of this PSA substance into their bloodstream. So instead of having a PSA of 1 or 2, they have a PSA of 5 or 6 or 7. But it's not specific for cancer. That's the problem with it. It can be high in men with BPH. It can be high in men with prostatitis. But it was used starting in about the 90s as a screening tool for prostate cancer. And it's highly effective at finding prostate cancer. The problem you're hearing about in the press nowadays is that we kind of got too good at finding prostate cancer. We found a lot of prostate cancers using PSA screening in men who were never going to get sick from their prostate cancer, who don't need to be treated for their prostate cancer. So the estimates are that in our country that we're kind of over-treating almost half, 40% of the men who we diagnose with prostate cancer don't need to be treated for their prostate cancer. But what we're finding now is that the younger guys especially should be screened, guys in their 40s and guys who have a family history of prostate cancer. If your father had prostate cancer, or if you're African American, or as I said, men over 40, we recommend a PSA as a baseline, and then every couple of years thereafter. We probably shouldn't be screening men in their late 70s and 80s because, and why is that? Because some men in their 80s come in and I try to explain this to them and they get very angry. They say, well, you know, my life is worth just as much as a 45-year-old man's life. And that's absolutely true. But we don't want to find, as I describe it to men, we don't want to find in an 80-year-old, we don't want to find a little speck of prostate cancer that big. And that's what PSA allows us to do. We can find tiny little cancers in men. Well, if we found that in an 81-year-old who, like Warren Buffett, this was in the news, Warren Buffett was just diagnosed with prostate cancer. Okay, he's 83 or 84. Then you're going to be tempted to treat that little small cancer. Okay, well, the problem with that is the treatment, the studies have shown the treatment of prostate cancer in men in their 80s is usually worse than leaving the cancer alone, because you can get terrible side effects from the radiation or from surgery or from things of that nature. So the experts worldwide on prostate cancer are trying to move shift the emphasis to guys in their 40s and 50s as far as cancer screening goes. Prostate cancer doesn't typically cause symptoms. In other words, it's just a little speck of cells that big sitting in a man's prostate. He's not going to feel that he has this growth unless it gets really advanced, which doesn't happen very often. Usually we're finding prostate cancers much more now from PSA screening at this very small early stage before it causes any symptoms. And it's similar to women who get screened for breast cancer with mammograms. Okay, yes, we want women to do self-exams, but basically if you're a woman, you want to find your breast cancer before you can feel it. Okay, you want it found as a tiny spot on a mammogram that gets biopsied, and then you get your lumpectomy and your radiation. If you wait until you can feel a hard spot in a woman's breast, then it becomes a harder cancer to cure. Well, it's the same principle for prostate cancer. You want to find the cancer when it's just a small speck with PSA screening in younger guys especially. You don't want to wait until you feel a hard nodule this big in the prostate or until it's causing symptoms, because if you wait until that happens, oftentimes it's too late to cure, and you wind up having to look to other treatments. For patients that are diagnosed with prostate cancer, you know, the most common treatments are you either radiate it or you remove it, and I won't go into the details about which is better and which isn't better, but they're both highly effective treatments. Some men decide to get their prostate removed, some men decide to get their prostate radiated. They both have kind of unique side effects that we can't go into here. So anyway, I've described the three common things that we see in urology for men's health issues. The three most common are BPH, which is the benign prostate hyperplasia, the growth, the swelling of the gland that occurs with aging. And then there's prostatitis, which we see in younger guys. And then there's prostate cancer, which we think men should be screened for starting at age 40. That was the majority of my talk. I can talk about any other subjects that you guys want to talk about. I can talk about kidney stones, about ED as it's called. I can talk about anything else that people are interested in. But thanks for listening. Yes, sir. I don't think so. I think BPH you see in all races at roughly equivalent amounts, but prostate cancer is much higher in certain races and tends to present at a later stage in certain races. And there's been a lot of work done on diet. For example, Japanese males have a low rate of prostate cancer. Is there something in the Japanese diet, you know, with their rice consumption or with their lack of certain foods that they're not eating that protects them from prostate cancer? There's been a lot of research about that. But to answer your question, no. I think the increased risk of prostate cancer in African Americans is not associated with a higher risk of BPH or prostatitis, the other condition. There's been books written about that recently. It's very difficult to prove that diet, as everyone knows, you know, do cell phones cause brain cancer? Well, one study says yes, they do, and then 2 years later a study says no, they don't. For prostate cancer, it's quite similar. Every 5 years, there's a new diet element that is either touted as a cause or a prevention for prostate cancer. But most of the emphasis has recently been going on vitamin D as a protector against prostate cancer, selenium in the diet, zinc in the diet, things of that nature, saw palmetto. There is some rough evidence that those can protect a man from prostate cancer. To answer your question, they tend to run together, but there's no cause and effect between BPH and ED. For prostate cancer, yes. For benign prostate enlargement, this TURP that I described, the roto-rooter that men call it, has been pretty much the same operation for 80 years. Now we have new ways of doing it. We use lasers now. We don't go in with a scope anymore and trim away tissue or cut away tissue through the scope, which is what we did for 50 years. Now we pass the scope in here and we hollow it out using a laser. So yes, that has reduced primarily the bleeding complications that used to occur. For prostate cancer, there's 10 different ways to remove the prostate for cancer, and the more recently developed techniques have decreased the side effects, if that's what you're describing. What's called the Da Vinci, the robotic technique, has decreased blood loss and decreased pain, so men go home quicker. So yes, there's been technological improvements not only for treating prostate cancer with surgery, but also for treating BPH with surgery. If you look at what kills men, it's far and away high blood pressure, high cholesterol, overweight. I mean, those are the three big killers of men that cause heart disease. And so you need to go to your internist or your family doctor and get your cholesterol checked, your LDLs, your HDLs, stop smoking if you smoke, and mostly it's blood pressure. Blood pressure is the big killer in this country, you know, and it's been recognized since the 1950s. And we have all these great drugs now to control blood pressure. So far and away, that's the most. As far as cancer screenings go, it's the only ones that have been shown to be effective. Really, is the main one is colonoscopy, just as it is in women.
What age do you start that one at?
I'm not a gastroenterologist, so don't quote me. But most people say unless you have a history of some kind of familial, there's something called familial polyposis of the colon. Unless you have something like that, most people say age 50. You should get your initial evaluation by a gastroenterologist and a screening colonoscopy, and if that's okay, now they've become less stringent about follow-up, which is good. They've stretched it out to 7 to 10 years now between colonoscopies, so that's wonderful. For women, you would add in obviously mammography, but colonoscopy is important in women as well. But screening for lung cancer has not panned out. You know, there's people that have said, well, should we get chest x-rays or CAT scans every few years on men and women, and that hasn't panned out. Pancreas cancer screening, stomach cancer screening, none of it has been shown to be cost effective. And even prostate cancer screening is up for debate. There's people that feel PSA screening for prostate cancer is unnecessary and doesn't save very many lives. In urology, we disagree with that. And we think the data in the years ahead will clearly show that it does reduce mortality, just like mammograms reduce mortality for women from breast cancer. But in urology, we don't quite have the data. The data's not quite mature yet. All right.
This has been great.
Okay. Yeah, I hope it makes sense, some of it.